Yeah, welcome, Dr. Maria.
Welcome.
Welcome. We are so for this second Metabolic Health Conference, and you are also one of the pioneers in the space of low carb nutrition. And we will come to that why I call you pioneer. So we'll come to that very shortly. And we are so happy to have you again, or have a diabetologist, an endocrinologist, a low carb endocrinologist on the first day of the second show. So what I'll do is I will briefly introduce Dr. Mariela. So before that, of course, all of you know that I'm Shashikant Iyengar, a low carb nutritionist or a metabolic health coach associated with D Life. And with me, of course, my co-organizer, Anup Singh. Anup Singh is the big daddy of low carb in India. He has started the oldest, largest, and the award-winning low carb platform of India called dlife.in. So it's not only a forum, but also it's now also an academy which rolls out an army of low carb nutritionists via low carb nutrition diploma, which was pioneered by Anup back in 2020. So this is a big thing which is happening in the Indian metabolic health space. So Anup, you want to tell a couple of things before we start?
Yeah, basically, first of all, welcome, Dr. Mariela. And as Shashi said, thank you for accepting our invite. And as far as D-Life is concerned, we started the community as a community in 2014. And slowly we moved to take it to a setup where it becomes no more a community, but a platform where community is very small part of the entire setup. Now, in 2020, we, came up with the course because by then MNT of ADA had low carb and very low carb included. So that provided us the legal backing sort of to have it going. But unfortunately, 2 years everything was down because of COVID. And then from 2023 onwards, 2022, 2023 onwards, it has picked up. And we now have, fortunately, from India, 19 doctors registered for the program. So it's growing. That's the story in short.
That's fabulous.
Thank you.
So I'll introduce Dr. Mariela. Dr. Mariela Glandt is an endocrinologist trained at the Harvard and Columbia with more than 2 decades of experience in treating metabolic disease. So she's also co-founder of Ona Health, a virtual diabetes clinic that combines optimal medicine, nutritional science, technology, and behavioral therapy in order to reverse type 2 diabetes. Music to the ears of all of us. So she's the director of Glandt Center for Diabetes Care in Tel Aviv, a multidisciplinary clinic that uses ketogenic diet as the main tool for treatment of diabetes. As a need that arose from a practice, she co-founded Eat Sane, a company that makes low-carb food with no artificial sweeteners. She is also co-founder of Metabolics, a non-profit organization in Israel that aims to educate people and help them achieve optimal metabolic health. So I called her pioneer because she had hosted the first low-carb conference in Israel sometime back. So just tell us couple of things about that conference. I read that long back, and I was, during those time, it was just one of those formative years for us, and we were very excited to see that one more country organized low carb conference. At the time, we used to talk to Anup that we were dreaming about low carb conference right from 2017. But during those times, such conferences always used to encourage us that one more country has now adopted low carb conference, and why not we also? So can you speak something about that conference?
Oh, yeah, it was just one of the best things I've ever done in my life, really. What happened was I was at a low carb conference in the US, and I was like, I have got to bring this to Israel. And I was really, really excited. So when I came home, I actually contacted Gary Taubes. And I said, Gary, what do you think about doing a conference in Israel? And he was super supportive and said, great, let me help you. And he sent out emails to a lot of people that are leaders in the low carb world. And next thing I know, 8 people had answered yes, they're coming to a conference in Israel. And I, of course, have nothing, right? I don't have any money. I don't have anything. Really, it just came together through donations from patients. It came together with Ariel Shitrit, who became my co-founder in Metabolics. We said, okay, let's form a nonprofit. Let's do this. And that's how it started. And it was really funny. My husband is like, you're completely insane. This thing ended up costing $150,000 or something like this, which came 100% from donations from patients, because, you know, this is not sponsored by pharma and such a thing doesn't exist. So when I went to my first donor, who was a dear patient, said to me, I'm going to give you money, but you got to do this somewhere really nice. And I said, okay. So we've through a whole bunch of, we got to a really nice hotel, the Hilton and everything. And the guy who runs the conference at the Hilton also had diabetes. So like it all, he wanted to help. And he's like, no problem. We'll get this together in 5 seconds. I'm like, no, you don't understand. There is no pharma involved here. And he was like, what are you talking about? There's never been a conference without pharma. I was like, well, this is going to be the first one. And it was, and you know, it was so great. I mean, 2 days of people sitting by the edge of their seat till 5 p.m. The organizer said, no way, people after lunch, they go home. I said, no, you will see. People will not go home. And at 5 p.m., everybody was like, there were 500 people. Maybe for India, that's not a lot. For Israel, that's a huge amount of people. That we were, you know, it was just so exciting and so polemic. The last discussion was a discussion between a conventional doctor, head of a hospital, and Steve Finney and Ivor Cummings. It was heated. The people were almost throwing tomatoes at each other. It was really fantastic. Anyway, it's been hard to replicate this because it's so much work. You guys are very aware of this. We've had 3 of these conferences. Hopefully we will have more in the future. But the fact that that there is no pharma and that we need to generate money somehow is the big challenge. So, you know, this is where we're at right now. But
so you know that this program is also, there is no funding. We are pooling in internally. All the members are pooling in to run this. We are doing it virtual. We are not doing physical because it requires a lot of fund. But we thought we will start this way. There has to be, the ball has been set rolling with this way. Maybe in future we might do, if we get funding, we will do those physical conferences. We can invite guests from abroad. But as of now, everything is being done virtually. And thanks to all low carb leaders like you, that you all have agreed to come for this conference, spend 45 minutes, half an hour, 1 hour with us. And you know, we are not paying any of the speakers anything. So it is the love and kindness of all of you that you could come and speak to India and contribute your knowledge. And you know, people can make an informed decision now, or whether they want to adopt low carb for various metabolic disease.
Yeah, it is so great that you're doing this. You know, it's amazing. Of course, I'm going to participate if I'm invited, because, you know, India is in such a tough place right now when it comes to metabolic health. So we've got to get the message out ASAP.
Anup, we can start.
Yeah, so we can start with a very common question, you know, that as a mainstream doctor, what made you switch to low carb for treating diabetes or metabolic syndrome?
Great question. I think it was the combination of a few things that came together. One of them was my best friend who had discovered the low carb movement. She had a website called thesweetlife.org and started looking into this. And her brother, Sam Apple, they had very much looked into this and understood this way before I did. And they were kind of telling me about this. And I was listening, but not quite getting it, because, you know, it made sense, of course, lower the carbs, but, you know, of course, but the truth is that really understanding what that implicates, what that means, is a whole other level, right? And it was then when I saw the Sarah Hallberg video, How to Reverse Diabetes by Ignoring the Guidelines, and then something just clicked, and I was like, I'm doing everything wrong. Like, what's going on here? You know, and I went through this like really strange time in life where I was like, literally, you know, I felt like my ground was shaking because everything I had learned for the last 20 years was upside down. And I was really good at maintaining blood sugars and adding more medication so that the A1C would look good, but that didn't make me a good doctor. And that really understanding the concept of metabolic health, which is a whole new field really that we don't learn about as an endocrinologist, really rocked my world. And that's how I started. That was a combination of having heard about it from Jessica and Sam Apple, and then having the Sarah Hallberg video. Unfortunately, I admit that I had to hear it from another doctor to get the final confirmation that this, that you're not crazy, that this makes sense. And then Jason Fung and all these people that were already in this field that were practicing doctors gave me kind of like the confidence to start on my own. So after reading and reading and reading, I was lucky to be able to implement this. And we have treated some 3,500 patients by now using our protocols.
Dr. Mariela, it is at this juncture, let me tell you that Sarah Hallberg's video has changed the life of many, including us. And it is so gracious of you to accept that. Watching that video made you rethink about the way you are doing, and you decided that moment that what you are doing is not correct. Though you required confirmation from some other doctor, that is all okay. But I think that made you think, because there are many who have seen this video and they have either rejected it or called her as quack or charlatan. This, I know this. But there are very few like you who have really understood that, and you have admitted that what you are doing may require a change of track. And one single person can change a trajectory. That's what I always believe, that it doesn't matter if thousands don't change, but if you change, you are going to help hundreds and thousands, and which are proved with more than 3,000 cases. Even one person helped in your lifetime to reverse diabetes itself is a big thing in this planet Earth. So I think it's very good. Quite nice to hear again. Some of the doctors have heard this story from their patients and then they change their practice. We know the doctor like Unwin or Eric Westman, they heard about Atkins and then they change the trajectory. Whereas you have seen Hallberg's video and then you have changed your trajectory. So that's how it is.
Right. It's that moment where you're like, you get it and you're like, what's going on? And then,
Anup?
Yeah, go ahead.
Yeah, so, continuing from the previous question, the mainstream still recommends high carb, low fat, or maybe whatever fat, but the focus is on high carb, 60% roundabout. Now, as you have seen, it's a criminal advice, so to say. But why do they do this?
Well, I think it's complex. I do think that doctors have the best intentions for sure. I do really believe that they think that they're doing the right thing. It's just that the educational system is so messed up at so many levels, starting with the guidelines. So, even though, as you said, the ADA has admitted that this is the diet with the most evidence, it is written in very, very small letters, right? And this should be blasted out all over the news, but it's not. And I think it's because of all the special interests involved in the ADA and all the special interests involved in the guidelines period from the government. And this leads to, most of us doctors we just follow. We're followers. They tell you to use this, you use this, and you kind of believe your mentors. And it's really, really hard to step away from that and to find the time to educate yourself outside of everything you're giving at conferences. Because as we just mentioned at the beginning, every single conference that you're going to go to is going to be talking about Ozempic or drugs and doesn't have any incentive to talk about this. So the information is not there. It's not available to doctors in an easy way. So I think that what's happening is that doctors are waking up because it's coming from the people. And because of social media, like you said, But now the patient is like, wait a second, I'm like learning about this. I want to be better. And they're coming to the doctors with questions, and there's some doctors are listening. But in general, if you're going to wait for things to change from the institution down, I don't see that happening, or I see it happening very slowly, like too slowly given the size of this epidemic. So that's why conferences like this are so important.
Yeah, as
I
you said,
think-
top-down approach will not work because there are a lot many factors, including big dollars involved. And it's only bottom-up that is going to shake the system up, maybe slowly, maybe it will take time, but it will happen for sure.
I'm with you. I agree. That's why we created ONA also, ONA is aiming to reach, everybody. We want to, this is a platform, it's a service to really make this mainstream, to make this not something weird or in the fringes. This is a medical data-driven, data-proven service for reversing diabetes. And as you know, the data for a reversal of diabetes is absolutely strongest in the low-carb diet. So, but that's not enough to convince people. Not funny enough. It's just, it doesn't matter how much data we have. It's not enough. It's a psychological warfare more than anything.
I think that's why, even though it has come in ADA MNT at 2019, it is there somewhere, microscopically it is there. I think it is just to prevent any class action lawsuit. If it happens, they will say it is there. You go and fight with your doctor. I think that is how it is simply. That is how I think personally. They have just ensured themselves that nothing happens to them because it is there in the guideline. If someone takes them to court, they will say, go and sue your doctor because we have given the guideline. If you are not been informed, that is not our issue. So this is how I think. This is my thought.
That's why it's there.
That's all. So now coming back to the our discussion, did you face any pushback from your colleagues?
Oh, yes, all the time, all the time I get pushback constantly. I just had a patient in ONA who was doing fantastic, but then went to his doctor, and the doctor is like, well, you're going to kill yourself. And that's, at that point, it just makes you want to cry or scream, why this patient is feeling great. So, that's when I really get most upset because, when people have this much dissonance in their brain, it hijacks the treatment. That's why the support of the doctor and the family is so important. And we got to get them on board right away. We got to get the family understanding that, there's nothing wrong with having a nice piece of steak and salad. It's actually going to improve your health, not deter you from being healthy. It's really, the most important is to have the doctor aligned.
Yeah, if I can add to that, your case, the patient was told you're going to kill yourself, right? 2011, when I started, I was very, enthusiastic about it because I was getting good results. But when I went to the doctor, he says you will die of multiple organ failures because of high fat. That was one thing that I was.
And that is
terrible.
how many years?
And 14 years, almost 14 years down the line, I'm still alive, thankfully.
So I think, 2019 ADA, 2020 Diabetes Canada, and even Diabetes Australia have it in the guideline. And very recently, we know that Diabetes Australia is tied up with Defeat Diabetes, and they have included low-carb nutrition pattern as one of the best practices for type 2 diabetes. I think that's a big breakthrough which has happened for the first time anywhere in the world globally. This is the first mainstream diabetes association which has accepted and tied up with an organization.
Yeah, it's really, really amazing. Yeah.
Yeah, no.
Yeah, how safe is this ketogenic diet for diabetes? Because normally what we find is the moment word keto comes in, the ignorant endos, I would call them ignorant endos, the first thing that comes out is you will face DKA, that is diabetic ketoacidosis. Now that may be true for, that's primarily a type 1 phenomenon. And we are talking of dealing with majority who are, type 2 diabetics. So just to get your word across to such, group of people, how safe is ketogenic diet?
Extremely safe. It's true that the word keto throws off everybody. So maybe we should explain what we mean by this. So there's something called ketosis and something called ketoacidosis. And these are two different things. It's the presence of ketones, but it's about the amount of ketones. So what happens is when as insulin goes down, the body starts to use fat for energy. And insulin, of course, goes down when we don't eat carbs. And when we use fat for energy, some of that gets converted into ketones, which are acidic, and they're acids that can change the pH of the blood. At the level of when we use a ketogenic diet, this is controlled by the fact that there's still a low level of insulin always present. So we can never get into ketoacidosis if you are a type 2 diabetic. If you have insulin resistance, there is no possible way you can get into this condition called ketoacidosis. Ketoacidosis is how type 1 diabetes presents, because type 1 diabetes, which is the opposite of type 2 diabetes, presents because there's absolutely no insulin. And when there's no insulin, there's uncontrolled use of fat. And this uncontrolled use of fat liberates too many ketones. And these ketones now start to change the pH of the blood, and this becomes an emergency. So that's why doctors are like, keto. No. But it's a fundamental difference between ketosis, which is a healthy, amazing state that gives your body the capability of running at its best, your brain the capability of running, at its fullest potential, versus ketoacidosis, which is the condition that's pathologic and it is an emergency and is caused by complete lack of insulin. Now, it gets a little confusing in the fact that ketoacidosis can happen in the presence of the SGLT2 inhibitors. So when you add to the mix of type 2 diabetes this type of drug, then you need to really, that's the one caution I would give. If you don't take an SGLT2 inhibitor, such as Invokana or Jardiance or Forxiga, these are the three brand names that are for SGLT2s, that they can cause a lowering of insulin in your body that is so much so that it looks like you don't have any insulin at all. And then you can get into ketoacidosis. So that's just a word of caution. But, and that's why you should not do this while taking SGLT2s. In some cases, it can be fine-tuned, etc. But really, as a doctor, if you want to sleep at night, my experience is take the patient off SGLT2s. And then there's absolutely no risk of having any ketoacidosis. So it's very, very safe. Not just very safe, but it's just not possible to get into ketoacidosis.
So essentially, SGLT2I off the table, type 2 diabetics cannot land into ketoacidosis just by following low carb, right?
Correct.
Yes.
So how do we overcome? Do you have any strategies to overcome the fear of fat? Because generally, the first thing when they hear of fat is they think that we are going to get a heart attack the next day itself. And they think that we devour a lot of pure fat.
I think a lot of it has to do with the conviction in which they hear the information, right? Education. But, when I come to a patient, I'm like, just, this is what you eat. This is what you don't eat. This is good for you. This gives you satiety. This has been part of the human diet forever. This is, gives you vitamins and improves your HDL. This is an integral part of how you should be eating. Then what happens is something starts to click. I think it's really important to say this with not with any doubt, because I really have no doubt that saturated fat does not clog arteries. That I really, the more you read and the more you understand this, blaming the fat, the saturated fat, has been a huge mistake over the last 50 years. And therefore, the patient needs to understand that. And when they do, I think they start to befriend fat again.
I think there are n number of studies which shows that the sad fat is not really associated with any cardiovascular issue. It is either neutral or protective. In fact, pure study also has shown some protective effect of the dietary saturated fat, fat originating from dairy sources. So I think in India, the sad fat is primarily from dairy sources, and people are terribly afraid of using ghee or butter or any of the cheeses, local cheeses. So I think pure study has also shown, even there are Cochrane reviews also which shows that there is hardly any association. If at all there, it is only positive or either neutral to our health. So that's how it is, I think.
I know, it's so sad that they stopped using ghee, such an amazing source of fat, and then to stop that is a crime.
To expand on previous question, do you think there is a lot of hesitancy to accept that yes, we were wrong, and that's why saturated fat will be bad till eternity?
Oh, I hope not till eternity. I'm more optimistic than that. But it takes time for people to admit that, it takes time for paradigms to shift. And usually we have to wait a generation or two until the people who have been advocating this pass away, right? So it's a war that maybe our children will be able to win. I think it's really, really tough to get people to change their mind on saturated fat. You are right.
Yeah, next question would be that has TCR helped in type 1 diabetics?
Well, absolutely, because type 1 diabetes is a problem where the beta cells don't produce insulin. So then we have to replace insulin in a physiological way. Well, insulin has a very narrow therapeutic window, which means that you can get it wrong very easily. So you can get hypoglycemia or hyperglycemia if you don't dose the insulin correctly. So one of the things that happens is when you eliminate that carbohydrate from the diet, you have to guess your insulin dose a lot less. So you will always need a basal insulin, because that's type 1 diabetes. They don't even have that basal insulin. But if you get that basal insulin right, then you barely have to cover the meals. And by doing that, life becomes really much, much easier, much simpler for a patient with type 1 diabetes. The problem with type 1 is that most patients live in a roller coaster. Their sugar is high and then it's low, and it's really exhausting because they can't really ever get it right, and it's not their fault. It's the nature of insulin. So why make life so complicated when, one, you don't need any carbs? You can thrive, as we've seen by the work of Dykman and of course Bernstein, that type 1 doesn't require any carbohydrates. And no human actually carbohydrates is not necessary. You can live just fine on the body knows how to make, through gluconeogenesis, the right amount of carbs. So, and anyway, if you do eat vegetables, you will be getting some carbs. So it's not zero, but it's just that the amount of guessing goes down tremendously. And therefore, I think the quality of life it's a tremendous improvement.
So, Dr. Mariela, in the current day, there are a lot of new drugs available. If you see, probably sometime back, couple of decades back, we were just left with sulfonylurea, metformin, maybe glitazones, some secretagogues, and some insulin. Now we have widespread use of GLP-1, SGLT2 inhibitor, DPP-4, and even newer drugs like imeglimin has also come in, which offers better blood sugar control without the risk of hypo. And maybe 30-40 years back, the primary dependence were on sulfonylurea, which can cause hypo. Whereas with this drug, it do not cause hypo. They have a different mode of action. But with a plethora of drugs, are we able to achieve better control, or is our control only worse? What does the data say?
Well, as far as reaching control, we actually don't see that yet funny enough, in the data, we don't see people having better diabetes control. We see it worsening. There was a paper last year that shows that our ability to get people well controlled has not improved, but maybe we haven't given it enough time. And also, relatively speaking, because these drugs are so expensive, I don't think that many people, it seems like a complete craze, but I'm not sure that it makes a difference in the world right now yet, as far as like glycemic control. Probably for weight, we're it's the two different camps. But even then, we're talking about a few people in a sea of obesity, right? And these drugs are very, very expensive. Now, there are benefits to these drugs. First of all, unlike sulfonylureas, which increase insulin levels, these decrease insulin levels. So all the GLP-1s and SGLT2, as we mentioned before, if you're not going to do the diet, they do lower insulin. And whenever you lower insulin in a diabetic, that is a good thing, because type 2 diabetes by definition is too much insulin. So what we see is that GLP-1s lower insulin. They don't increase it like people think. People think that it actually increases insulin overall. It doesn't, which is why you can never have a situation where you're increasing insulin and losing weight. That doesn't happen, okay? And sure enough, that's what GLP-1s do. They lower insulin. And because of that, probably, they have other effects that are good long-term, which have to do with improving blood pressure and some cardiovascular data. Now, there are negatives to it. Sorry?
Sorry, no.
Okay. There are side effects with it to this. And these side effects are serious. They decrease lean muscle mass. They also cause a lot of GI upset in a lot of people. Maybe about half people don't feel great on them. They're complicated medications in that sense, because also we don't have a lot of long-term data. Sometimes they're very useful for giving a positive feedback and helping people get on a low-carb diet. So I'm not against them. I like to work with them. Some people who are seriously obese or seriously insulin resistant might do great on a low dose of a GLP-1 and a diet, and then they really are able to hold on to the diet in a much better way. So I think we need to embrace this wave and say, okay, how can we use it to our advantage? And we can, but we should try to always combine it with the diet, because otherwise what happens is that you're basically starving people. You're putting with the GLP-1s that are on a very, very low calorie diet. And of course, the minute you stop it, it will rebound like crazy. But not just that, you're basically you're decreasing the energy expenditure. What we know on low carb is that we increase the energy expenditure, unlike any other diet. The body now has more energy, which is why people after like 6 months start to say, I want to go to the gym, which is unheard of, right? In other diets, people are more tired over time because their energy expenditure decreases. But here you're creating more ATP, you're liberating all that energy that you have stored, and you have the capability of being satiated and feeling good. So we don't really need that. Once we're deep in keto or at least in a low carb diet, you don't even have to be deep. The satiety by itself helps you hold on to the diet. So you don't need the GLP-1s as much. So sometimes the GLP-1 is a great bridge. But so, we do appreciate this, but I certainly don't see it as a solution overall.
That means a combination of diet and this drug would work much better than without than giving a random dietary advice and then let them take all the drugs. And we see that sometimes we do get a lot of clients because we are health coaches, and then they started with one pill and then they reached everything. And in India, most of these drugs are also off patent. For example, you can get DPP-4 SGLT2 inhibitor at a much lower price than the patented prices. So most can afford, though we spend from our pocket, but then they come with a plethora of drugs, still HbA1c of 9. So this is what we see, and what we see, there's a wide gap in they have not been trained well or informed well about their dietary practices. They have been eating anything they want, and Indian diet is as it is high carb. So I think, as you rightly
know.
say, probably a combination of both actually would work very well. Yeah, no.
Yeah, doctor. So what are the complications of diabetes? Because diabetes per se by itself is just a number. It's the damages that happen all around the body that's concerning. So what are the complications and are they preventable?
Right. So there are two types of complications. There's the complications that come from having high glucose, and there are complications that come from having high insulin, because insulin by itself causes complications. So we have basically every organ in the body can be affected by diabetes, by having this combination. Number one, I would say is, well, first of all, there are the acute complications, which is how we feel every day, the tiredness that comes with hyperglycemia, the fact that you're just not living your best life, for sure. But over time, what happens is that the heart gets affected, the brain gets affected, the small capillaries of the legs get affected, causing neuropathy. I mean, literally every single, sexual function, every single organ. Literally, I can go into every single organ and talk about complications that arise from it. But diabetics still die number one of heart disease. And we know that high insulin puts us at risk for cardiovascular disease. So when you combine the high insulin with the high sugar, that really causes a lot of damage, and basically leads to the small arteries are not able to dilate. The capillaries actually are not oxygenating. And so this leads to, of course, all the amputations and the complications that we see. The kidney, every single organ, as I said, it still remains to be the number one cause of kidney transplant. But we're also seeing is that we're having now alcohol is no longer the number one cause of liver transplant. It's now the fatty liver, which is again insulin resistance, which is what we also see in diabetes, of course. So the liver is getting really sick from this food that is not appropriate, meaning the sugars and the seed oils combined together, leading to a very inflammatory state for the liver. So every single organ is affected.
So I think
from the ear, okay, from ringing in the ears, I'm talking every single organ, okay, the mouth with all of the infections increased, all sorts of surgeries that need to be done in the mouth. I mean, they're just eyes. I can go on.
I think very interesting. And Anup, I'll just jump into the next question. We'll come to the preventive space. What about this measuring fasting insulin resistance? How important is it in the context of diabetes prevention? Or do you also measure in newly detected diabetes? How is it? Because generally we see that there is a big ignorance in India as far as measuring the insulin is concerned. If you ask, most of the doctors here do not know anything about measuring insulin. They think that it is only for research purpose. So what is your context on insulin resistance, measuring insulin levels?
Well, I think it's very interesting because, it is more of an intellectual question. It doesn't really change our management, but it's really, really important for the patient to see that, because, insulin is supposed to rise when we eat and go down almost less than 4 between meals. So it's really important for the patient to understand that their insulin is high even when they're not eating. That means they're storing fat, whether they eat or don't eat, they're storing fat because that's what insulin does. So it's impossible to use your stored fat if your insulin is high. You've got to lower that insulin. And when you see it visually that your insulin is 20 or whatever the number is, but instead of 3, the way I would want it to be, then you're like, oh, I see. And it's kind of like an aha moment for the patient where they're like, oh, no wonder, because I'm not eating that much and I'm still gaining weight. So it helps, especially in the pre-diabetics.
What should be
So,
the level of insulin? Because the
well,
lab is wide from 2 to 25.
I know that makes it even more complicated to explain to the patient, right? Because the normal range makes no sense. The normal range should be in the context of whether you ate or didn't eat. But I like it less than 4.
And I think see, we in the low carb space, we always say it has to be around 6 and less. And Professor Noakes has mentioned one of the studies which has shown that if the insulin goes below 6, then fat oxidation happens. If it is above 6, fat oxidation does not happen. So I think that gives us that signal that probably 6 or below could be an optimal.
Yeah, maybe I'm too tough.
But then in this low carb space, like for us, for me or Anup, our insulin is very less. Our fasting insulin is around 2.5, and postprandial doesn't go beyond 15. So that's all. But then the lab range is so atrociously high that if they see a lab range of, let us say, 9, so it can be said that insulin is very less. Go and take your insulin secreting drugs. You put on sulfonylurea. And if it is 20, 21, they say, okay, you are in range, it is safe. Whereas we see that or these range are pathologically very high. So there could be obesity, very strong association of hypertension also. I see as a coach that if it crosses 12, 13, and then they are associated with hypertension also very, very frequently. So I think
absolutely, we need to get rid of that normal range. That's really causing a lot of harm.
I would call the range as criminally wide. It's criminally wide.
So I think, Anup, we still have around few minutes, so we'll just jump to the question. One important question I want to ask about the audit which you have published about your clinic. Please tell us about that. What exactly is it?
Oh, well, I thought I was inspired by Dr. Unwin, and I said, I'd like to see what kind of results we're getting in our clinic. Our clinic looks at real life data from a specialist clinic, meaning unlike what's been published, this is the only trial published from an endocrinologist clinic where, patients don't come it's not a routine visits all the time. So what we decided to do is look at time 0 and time 6 months. And that meant that we had to exclude a lot of people that we didn't have data on both, because you needed an A1C and weight at both points. So, life is messy. So that brought us down from 3,000 patients to 344. We also excluded anybody that had come for other reasons like weight loss or high blood pressure or other metabolic things. And so, in looking at that data, what's interesting also in our study is that this is a cohort of patients that have had diabetes on average for 12 years. And that's never been looked at before. Normally, it's a much shorter duration. So these are quite sick people. This is average. So a lot of them had diabetes for 20, 25 years. It's a range that, like I said, it's never been looked at before. And we see that it's still incredible and totally worth it to implement a low carb diet in this population, because everybody, 96% of patients improved, period. 79% of patients got off insulin. Out of those that were on insulin, were able to get off of it. I mean, that's really exciting, really, really unheard of. And about 1/3 of our patients were on GLP-1s. So that also gives us a more in-depth look at the combination of the diet with GLP-1s. But overall, medications were decreased, and I think it was a very encouraging to see, a very significant weight loss of 8 kilos, and just exactly what we would expect, an improvement in every single parameter: triglycerides, improvement in HDL going up, blood pressure, everything that we would like, including the fact that this is safe from a kidney perspective and nothing to worry about. The kidneys, this is another one of the myths that people worry about. They're concerned that eating protein in diabetics will lead to a worsening in kidney function, and it's actually the opposite. So I think it was a very encouraging and confirmatory audit that just tells us to keep going and with all the gusto.
I think such studies are very valuable, and it really gives us what is called as the real world data of what is happening. If you've been practicing low carb, what is the remission rate, what is the amount of weight loss or safety or reduction of medication. So we believe that, me and Anup, we believe that low carb nutrition is not just for remission, but it is also for better control. It is also for reduction of medication. So we have this three-pronged approach. Either you get off all the medication, reduce it, or at least with the same medication, better control. So that's how it is. Yeah, Anup, you can ask the next question. We still have 4 minutes to go.
Yeah, almost time then is ending. So what's your message to India?
Oh, let me think about this. I really find it a real shame that we're in this epidemic when it's so unnecessary. I think that India is so full of ancient wisdom that we need to draw from and get back to. Modernity has not been good for health in India. So we need to go back to eating ghee and to eating according to the circadian rhythm, to maintaining the strong family connections and everything that led to a society without diabetes. Once we started eating those seed oils and adding sugar to everything, things went wrong. So we've got to detox from the sugar, and we've got to go back to regular fats. So when you add sugar to a very high carbohydrate diet, and you add sugar, well, you're going to get in trouble. So we got to take the sugar out in order to prevent disease. Once we have disease, we have to go keto all the way, because once we have set in that insulin resistance, removing the sugar is not going to be enough. You're also going to have to remove the carbs. So for prevention, I would say no seed oils, no sugar. But once you want to reverse cardiovascular disease, or diabetes, and all the chronic diseases, you got to go really low carb, meaning basically protein and fat. So I would say do it now.
Thank you.
Mariela, before we wind up, what are your future plans? Do you plan any innovative things in the space of low carb, in the space of treatment? What do you think can be done better?
Well, you know what? Right now, I'm working full-time on Ona Health. We have a pilot in the Bronx where we're seeing just remarkable results. And what I'm seeing there is that, we're not limited by financial constraints. It's more about education. And this is the beauty of what I'm seeing, people reversing and changing their lives around by just being educated and told what to eat and what not to eat. And so I right now, my goal is especially to reach underserved communities, and give people a chance. Nobody needs to be sick. This is completely preventable, completely.
Thank you. So, Dr. Mariela, thank you very much for accepting this invite. And I think you, an endocrinologist, coming and sharing this knowledge in the Indian context, Indian space, is very, very important for us. We are reassured that we are always on the right path when we have international thought leaders like you coming out and telling us how many patients you have treated, what are the research publications, the kind of audit you have published. It's going to help us a lot that people can make informed decisions. Thank you. Thank you very much.
Thank you very much for inviting me.
Thank you.
Thank you, Mariela, and we'll see you again in future programs. Thank you. Namaste from India.
Namaste.
Namaste.